Assalamu alaikum. I am Dr Anam Haider, and today I will be discussing the very most common electrolyte imbalance which we see in hospitalized setting, and that is dysnatremia. So about dysnatremia, water imbalance leading to dysnatremia is the most common electrolyte imbalance observed in the clinical medicine. Two different pathways control this tightly regulated mechanism. These include osmoregulation via ADH and volume regulation via RAS and natriuretic hormones. Water and sodium balance are regulated independently by these pathways, which prevent large changes in plasma osmolality and the effective circulating volume. Severe sodium disorders are related with increased morbidity and mortality. Even mild hyponatremia, especially when it complicates conditions such as heart failure and sepsis. So moving on, starting with hyponatremia. Hyponatremia is defined as a sodium of less than 135 millimole per liter. When we find hyponatremia in any labs, so we order a set of investigations to rule out the cause of hyponatremia, which includes serum osmolarity, urine osmolarity, spot urinary sodium, serum TSH, and morning cortisol. Depending on the osmolarity and volume status, we narrow down our differentials. So first of all, when we see serum osmolarity, we can divide them into normal, low, or high. If it's normal serum osmolarity with hyponatremia, the causes include hyperproteinemia and hyperlipidemia. If the patient has hyperosmolarity, so that is known as hypertonic hyponatremia, and its causes include hyperglycemia, mannitol, sorbitol, glycol, or glycerol, or any exposure to radio contrast agents. If there is low serum osmolarity, that is less than 280 milliosmoles per kg, then it is known as hypotonic hyponatremia. We move on to further evaluate by the volume status. As we see the volume status of the patients and divide hyponatremia further into three categories, either hypovolumic, euvolumic, or hypervolumic. So if the patient is hypovolumic, we measure serum urinary spot urinary osmolarity sodium, spot urinary sodium. If it is greater than 20, then there are renal losses, which can be due to either diuretic excess, mineralocorticoid deficiency, salt losing nephropathy, bicarbonate urea, ketone urea, osmotic diuresis, or cerebral salt wasting. If the urinary sodium is less than 20, then there must be any extra renal losses, which can be secondary to vomiting, diarrhea, third is spacing of fluids, such as in cases of burns, trauma, or pancreatitis. If the patient is euvolumic, so that is euvolumic hyponatremia. It can be secondary to few conditions such as glucocorticoid deficiency, hypothyroidism, stress, drugs, most common of which is SSRIs and SIADH. So if the patient is hypervolumic and we measure the urinary sodium, if it's greater than 20, then it is mainly secondary to acute or chronic kidney injury. If it is less than 20, then it can be secondary to nephrotic syndrome, cirrhosis, or cardiac failure. So the clinical manifestations of hyponatremia, most patients with the hyponatremia or serum sodium above 120 are usually asymptomatic. Once it's below 125, then its symptoms varies is from simple headache, yawning, lethargy, nausea to reversible ataxia, psychosis, seizures, and coma. So how to treat hyponatremia? If we have to treat hyponatremia, we have to divide it either the patient is symptomatic or asymptomatic. Symptomatic hyponatremia needs immediate treatment, and we further divide it into whether it is acute or chronic. If it's acute, that means the duration is known that the sodium is low less than 48 hours, then emergency correction is needed, which is done by hypertonic saline, 3% saline at 1 to 2 ml per kg per hour. It can also be co-administered with furosemide if the patient is hypervolemic. In chronic symptomatic patients, that is, the duration is greater than 48 hours or unknown, so we again suggest immediate correction and with hypertonic saline 1 to 2 milligram per kg per hour, or if seizures, or otherwise isotonic saline can be given in co-administration with furosemide, and change of water restriction up to 10% of increase in of sodium, or if symptoms resolve. But during this management, there is the need of frequent measurement of serum and urinary electrolytes. Do not correct sodium, serum sodium greater than 12 millimole per liter per 24 hours, and the usual goal of correction is 8 millimole per liter in 24 hours. If the patient is asymptomatic, mainly in cases of chronic, that is really very rarely, and in less than 48 hours, there is no immediate correction needed. There is only long-term management. We have to identify and treat the reversible etiologies. Is a water restriction, demeclocycline can be given, urea tablets can be given, or V2 receptor antagonist can be given. So as we are saying that we have a specific goal of correction for 24 hours, and that needs is not to be overcorrected. Because there is always risk of osmotic demyelination syndrome with the overcorrection of sodium, also known as CPM. The risk of cerebral pontine myelinosis is related to the severity and chronicity of hyponatremia. It really occurs with serum sodium above 120 millimole per liter or acute onset of hyponatremia. Initially, there is generalized encephalopathy associated with rapid correction of sodium. After 2 to 3 days after correction, the patient displays behavioral changes, cranial nerve palsies, and progressive weakness, culminating in quadriplegia and a locked-in syndrome. MRI shows some non-enhancing and hyper-intense pontine and extrapontine lesions. These lesions may not appear until 2 weeks after development, so a diagnosis of myelinosis should not be excluded if the imaging is initially normal. So because of this only, it is very important not to overcorrect sodium. So moving on to hypernatremic disorders, hypernatremia is defined as a serum sodium of greater than 145 millimole per liter. And again, the diagnostic approach which remains with the volume assessment. We have to assess the volume status first of all, whether the patient is hypovolemic, euvolemic, or hypervolemic. If the patient is hypovolemic and the urinary sodium is greater than 20 millimole per liter, then there is renal losses, which can be secondary to osmotic or loop diuretic, post-obstruction, or in any other intrinsic renal diseases. If the urine osmolarity is less than 20, then the cause can be from extra-renal cause, which includes excessive sweating, burns, diarrhea, or any fistula. If the patient is euvolemic, then it can be the renal or extra-renal losses. If the renal losses includes diabetes insipidus or hypodipsia, whereas extra-renal losses includes insensible losses through respiratory or dermal. If the patient is hypervolemic and urinary sodium is greater than 20, then we have to find the sources of sodium gains. It can be due to secondary to some diseases such as primary hyperaldosteronism, Cushing syndrome, or from drugs such as NaCl tablets, hypertonic sodium bicarbonate, hypertonic dialysis. So once the cause is ruled out, we have to look for the sign and symptoms and management. And the sign and symptoms includes altered mental status, lethargy, irritability, restlessness, seizures, usually in children, muscle twitching, hyperreflexia, and spasticity. Fever, nausea, or vomiting, labored breathing, and intense thirst can also occur. In adults with serum sodium above 160, it is mostly associated with 75% mortality, reflecting associated comorbidities rather than hypernatremia itself. So moving on to management of hypernatremia, it depends upon the volume status of the patient. If the patient is euvolemic, we need to correct the water deficit. We need to calculate first the water deficit of the patient, and it needs to be corrected. Replaced basically. So it can be replaced either by administration of 0.45% saline in 5% dextrose, or with oral water to replace this deficit and the ongoing losses. In the cases with central DI, with severe losses, aqueous vasopressin can also be given and the serum sodium needs to be followed very carefully. In long-term therapy and in nephrogenic DI, the mainstay of treatment remains the removing of the offending drug, low sodium diet, thiazide diuretics, amiloride for lithium-induced DI, and the correction of potassium and calcium. So if the patient is hypovolumic, we need to first correct the volume deficit, which can be done with isotonic saline until the hypovolemia improves. Once it's done, then we have to move forward for the correction of the water deficit, which is done with the hypotonic saline or the 5% dextrose or the oral water. And we also need to treat the etiology itself, whether it is the insulin in obstruction or removal of the osmotic diuresis. And if the patient is hypervolumic, then we need to remove the excess sodium which is coming either from the offending agents. We need to discontinue that, and we can also give furosemide, and if ultimately we can do hemodialysis as needed for the renal failure. So a little bit about dysnatremia and COVID-19 patients. Since hyponatremia is much common among hospitalized COVID-19 patients than expected, and COVID-19 registry analysis also found significant association of hyponatremia and hypertensive patients. The underlying mechanism is supposed to be the increased pro-inflammatory cytokine release like interleukin-6, which induces the ADH production by direct non-osmotic stimulation of ADH. Indirect stimulation of IL-6 is mediated by injury to the alveolar basement membrane in resulting in activation of the hypoxic pulmonary vasoconstriction pathway that leads to ADH release. Similarly, hypernatremia patients treated with the medical ICU varied between 6 to 26%. And during the treatment of patients with severe COVID-19, there was a frequent development of treatment-resistant hypernatremia, possibly due to diuretics and steroids. It's used as a part of infection treatment. And serum sodium levels over 145 or below 135 are independent risk factors for high mortality in hospitalized COVID-19 patients and associated with poor prognosis. Thank you.